All right. Well, it would be better that if you, I think I have got 6 participants. I don't know who these participants are. Anyway, PRS Hospital, Majida, 1 plus Devika. Okay. We have one new DNB candidate also. She has joined from some other hospital, Dr. Devika. Devika, you're welcome. Are you with us?
Thank you, sir.
Yeah,
Yes, sir. Yes.
yeah.
Thank you, sir.
Okay, very nice of you to join. See, we have been doing this for the last one month or 1.5 months. Every Wednesday and Friday, I welcome anybody to join. It is between 3 and 5 p.m., mainly meant for PRS Hospital. But few other doctors like Anju Kanmani and Dr. Gopakumar does join, some of the 5 members, then contribute. If everybody is free to contribute. Now, the difference is the PRS hospital is being taught by multiple consultants. They are dealing with but certain portions which are the core area of pediatrics, I am going into in full detail. Therefore, I emphasize on the part of practice, your practice tomorrow when you become a pediatrician. And also I emphasize on the part of your examination. Mine is basically topics which I go into depth, which you should know. As a pediatrician, 3 subjects I feel are always very important. One is, of course, immunization, where you are the final master. And then you have what is called as uh, what we call as the nutrition and growth and development. Therefore, I am dwelling into immunization. We have already covered 4 or 5 slides. We have put 3 videos, each with 50 presentation. And then after the videos, I ask the MCQ. I send the video and then I ask the MCQ so that you don't miss the point. I'm fully aware that MCQs are not there in DependB exam, but this tests the primary knowledge of you in the field. Okay. With this introduction to Devika, now I will proceed. The PRS hospital is with me, I hope. Can you read the first slide, please? Somebody from PRS?
Yes, sir.
Yeah.
Which type of immunity is primarily responsible for early protective efficacy of most vaccines?
Quick. Is it so difficult, Dr. Mosen? Mosen is a second year DNB student in PRS hospital. Yeah.
Sir.
Devika, by the time is a first year DNB student. She has just joined. She is a lateral entry, I think. Okay, carry on. Is it so difficult? The answer comes next. What is it? See, in every answer, I give you the reference also. Can read the answer.
Yes. Humoral immunity. Purple Book IAP Guidebook of Immunization 2022. Early protective efficacy of currently available vaccines is primarily confirmed by the induction of antigen-specific antibodies that are capable of binding specifically to a toxin or a pathogen.
See, here the problem, which type of immunity primarily responsible for early protective efficacy of most vaccines, they have asked. You understand? If there was no vaccines, probably innate immunity would have been the reason. That is one which acts immediately, but it is not that potent. And it takes about 7 days, even if memory cells are there, for the humoral immunity to act. It's not the cell-mediated immunity. Therefore, you had to read the question in forward. Which type of immunity is primarily responsible for early protective efficacy? The answer would have been innate immunity. You know, innate and acquired immunity are there. You have to read the purple book, the introduction books. Okay, now, therefore, this is the particular slide. Purple book, I hope, is Devika, you have it with you. It is the IAP Guidebook of Immunization. You should have it either in the PDF form or the original text. Read it from cover to cover, though it does contain some mistakes. Therefore, we had sent this. We have read this already. Now, coming to our next question. Mohsin, you can read it fast. The first,
The role of cell-mediated
yeah.
in vaccines with T-dependent antigen is mainly by
These we have discussed before. This should be very clear. Well, I didn't put up the diagram for the answer. This is basic immunology of immunization. Therefore, the DNB, they say that you have a separate paper for basic anatomy and physiology. Therefore, this should be an important answer. Gopika, you're there?
B. Supporting antibody production.
Yes, sir.
What's the answer then? I thought these you will answer very fast because I showed it in the slides. Gopika, I will upload. I would upload the slides for you so that. But even otherwise, you should know. Direct neutralization of pathogens, supporting antibody production, inducing complement, enhancing phagocytosis. I thought the answer was straightforward because we were discussing again and again. I thought I'll be repeating the questions again and again. You see, in the CME, it is the T cell which allow the B cell to enter the germinal center, which it produces, which diagram I had shown many times before. And for Devika, you can see it when I upload the slide to you, send the slide to you. And you will
Okay, sir.
you read this answer, Mohsen.
Sir,
Can you read the answer?
B. Supporting antibody production.
Reference, that's okay. Reference, you need not read.
Reference.
Now, this is the slide which I
Yeah.
had, you can read only what is highlighted. Can you tell me?
The role of CMI in currently used vaccine that have T-cell dependent antigen is mainly by supporting antibody production.
It supports the antibody production. It can produce CD8 T cytokine killer cells also, and that acts in only particularly in one type of vaccine, that is BCG. Remember, all other vaccine, it actually enhances the germinal center function. Okay, next question. Mohsen, you are alone in the library or what?
Sir.
Marginals.
Majida, can you read it then?
CD8 plus,
Yeah.
cytotoxic CD8 plus T lymphocyte contribute to vaccine-induced immunity by killing infected cells or secreting antiviral cytokines.
What is it? C, yeah?
Sir.
Okay. Tell it convincingly. What's the problem? CD4 and CD8 are important. CD4 is helper cell. CD8 is killer cell. Therefore, read the answer alone.
Correct answer is C, killing infected cells or secreting antiviral cytokines.
Okay. Now, you can read. This is the slide which I put up in you. For Devika, I would be sending it to you. Therefore, you can go through those slides. These were already taught to them about 2 weeks back, and therefore they're still having doubt about it. How do vaccine work, and what's the role of cell-mediated immunity? You can be asked a question. In basic immunology of immunization, they can ask you multiple questions, short questions, which should be asked according to me. What's the problem of neonatal vaccination? What's the problem of maternal immunization? What's the advantages? And what is the role of humoral immunity? What's the role of cell-mediated immunity? Therefore, this can be a short note for you. Yeah, Majida, can you read it?
Other important mechanism by which cell-mediated immunity works are by cytotoxic CD8 plus T lymphocytes that may limit the spread of infectious agent by recognizing and killing the infected cells or secreting specific antiviral cytokines.
Okay. Therefore, they go back into the slide and read it at home. Okay, if you want, you can read the whole slide now because you don't seem to be very confident. Okay, that's enough. I think we'll waste a lot of time. If you read from the beginning, It gives you your overall bird's idea how the role of cell-mediated immunity is. Okay. Marjorie, you read the whole slide now better because that's one of the fundamental things.
How do vaccines work? Role of cell-mediated immunity. Early protective efficacy of currently available vaccine is primarily conferred by the induction of antigen-specific antibodies that are capable of binding specifically to a toxin or a pathogen. The role of cell-mediated immunity in currently used vaccines that have T-dependent antigen is mainly by supporting antibody protection. Other important mechanism by
We have
which
already read it.
cell-mediated immunity
Yeah, go to the next line. Yeah.
T-cell independent antigens do not stimulate cell-mediated immunity and therefore do not produce long-lasting immunity. T-cell independent antigens can be converted to T-cell dependent antigens by conjugating them with the proteins.
This is the fundamental immunology. That's why we conjugate protein. We conjugated typhoid conjugate vaccine. Therefore, we make it into add a protein so that it becomes the T cell comes into play, and they allow them to enter the germinal center where they produce highly specific antibodies. The diagram is there in the slide. Now go to the next one. Has it changed for you?
T-cell independent antigens such as polysaccharides do not stimulate long-lasting immunity because they lack which of the following? Antigen presentation.
It's a stupid question, actually. They do not produce because T cell help is not there, it seems. T cell independent antigen. Yeah, I don't think this is a very clever answer. Anyway, the independent antigen polysaccharide vaccine, can you name one? Which is a polysaccharide vaccine which we give sometimes? Very rarely.
Typhoid.
Yeah, typhoid polysaccharide we don't give, we give conjugate vaccine. Sometimes we are forced to give pneumococcal polysaccharide vaccine 23 in specific situations like sickle cell disease or patient splenectomy, etc. Therefore, that is polysaccharide. If you give, you can give only after 2 years, and you can give only, it doesn't have a long-lasting effect. Why do you sometimes give typhoid polysaccharide vaccine? Because it's cheaper than the conjugate vaccine, and you have to keep on giving every 3 years. Okay, this must be very simple. Mohsen, can you read it?
How can T-cell independent antigens?
Yeah.
How can T cell antigen be converted into T cell dependent antigens?
Okay.
By conjugation with proteins.
Okay, that's a very simple answer. Okay. Now, not so much. I'm going through this fast because these are very simple answers. Next question.
Which of the following vaccine is known to rely primarily on T cell response for protection?
I told you several times. Which one? Quick. My God. I thought these things you look too simple, repetition for you. Primarily on cell-mediated immunity is the Bacillus book. Okay, read the answer now. Don't read the reference, read the answer.
Correct answer is C, Bacillus calmette-guerin, BCG.
And read the explanation.
BCG is the only current used human vaccine for which there is conclusive evidence that T cells are the main effectors.
Therefore, BCG is unique. That is the antibodies are not the responsible. That's why you can give it at birth. The maternal antibodies do not inhibit the BCG. Stressed it several times. Okay.
Helper T cells support immune responses by secreting.
The question is very important. What do they secrete? Okay. CD4 T cells. What do they secrete? I thought you would have read all this for your NEET examination because immunology is
Cytokines.
cytokines. What's the difficulty in that? It is cytokines, interferons through which these directly act. If they indirectly act, they act by making the B cell enter the germinal center and produce antibodies. That is more important in immunization in most of the vaccines, except BCG. Okay. You can read what is there in the bracket. These are all slides which we discussed. Okay. This is a revision. Read what is in the bracket.
The correct answer is C, cytokines.
Has the slide shifted to?
The helper T cells secrete proteins called cytokines that stimulate the proliferation and differentiation of T cells, as well as other cells, including B lymphocytes, macrophages, and natural killer cells.
Okay, that much is good. Okay, I don't want you to. The other points in the we have already discussed cytotoxic cells, clearance of intracellular pathogens. Anyway, now let's go to the. Has the slide changed to the next question?
No, sir.
Wait a little, it will change. There's some problem in it here. Where are we now? What is showing in the here?
Question: live attenuated vaccines typically generate which of the following immune responses?
Live attenuated vaccine. Well, the answer is a little difficult question. I don't understand the basis of it. They have written that, okay. See, live attenuated vaccines are like lateral infections. They produce both the primary and the secondary response. But I don't know why they have given the answer CD8 plus cytotoxic cells. And the reference is also Podkins vaccine, which I showed you. The CD8, you can see the slide. CD4 and T cells seem to support the evidence, support the persistence of protection. Can you see the blue slide?
Yes, sir.
Yeah, CD4 and T cells seem to support the persistence of protection against clinical pertussis. First sentence is there's indirect evidence that vaccine-induced T cells contribute the protection conferred by other vaccine. The CD4 T cells seems to support the persistence of protection against clinical pertussis in children primed in infancy, and vaccine-induced antibodies are vague. Anyway, I'm not sure that this is the answer to it. Anyway, we will skip that question. This is the next question. Can you read this?
Conjugation of bacterial polysaccharides to protein carriers enhances immunogenicity by recruiting which of the following cells?
You remember the diagram which I had put up again and again. For Devika, don't get worried about this because this will come up in the slides which I sent to you. We have illustrated this carefully. How does the immune response act? But those diagrams, I didn't put it up again because I didn't want to repeat in the answer. Which is the one?
CD4 plus T4.
Yeah, CD4 plus follicular helper cells is the answer to it. Okay. Now, next question. We are going a little fast, but we will come to that. Okay, tell me.
A hallmark of T-dependent responses is the induction of IFBD.
Quick.
B, sir.
Yeah. See, once it enters the germinal, I don't want to close this and start new and search for the diagram. I don't know why I didn't put up the diagram. I didn't. I thought you would answer very fast. Once it enters the germinal primary response, when the body comes out, it produces IgM, lower level of IgG, which have vanished very low level. Secondary response, it also enters the germinal center, produces memory cells. Secondary response, T-dependent activity, high affinity IgG will be produced and have very high levels with memory, even in the primary response. Therefore, hallmark is high affinity IgG with memory. Okay, the answer is right. Now you can read what is written in Nelson's textbook of pediatrics. Devika, you are there? I think she left.
Yes, sir. No, I'm here.
You read the slide then.
T lymphocyte-dependent responses tend to induce high levels of functional antibody with high avidity.
Okay.
The T-dependent responses mature over time from primarily an IgM response to persistent long-term IgG response and induce immunologic memory that leads to enhanced responses on boosting. T lymphocyte-dependent vaccines, which include protein moieties, induce good immune responses even in young infants.
Okay, this is the MCQs based on a video. The video shows beautiful diagrams about how this happens. I'll send it to you. Now, next slide. Gopika is there. Can you read?
What is the primary mechanism of immune protection induced by glycoconjugate vaccines?
I think we are going in the same questions are being repeated. Therefore, you should be able to answer it first.
Recruitment of
Yeah, so recruitment of CD4 and T follicular cells leading to high affinity antibodies. Therefore, read the answer.
recruitment of CD4 plus T helper cells leading to high affinity antibodies.
T follicular helper cells. Okay.
T follicular helper cells.
I'm sorry, I'm not able to put up the diagram anyway. Now read this answer to the
The conjugation of bacterial polysaccharide to a protein carrier, example glycoconjugate vaccines, provide foreign peptide antigens that are presented to the immune system and thus recruit antigen-specific CD4 plus T follicular helper cells in what is referred to as a T-dependent antibody response. A hallmark of T-dependent responses, which are also elicited by toxoid, protein, inactivated or live attenuated viral vaccines, is to induce higher affinity antibodies and immune memory.
Higher affinity antibodies and clone-specific antibodies and immune memory. Okay, next question. Now we go into early life. We had a discussion of early life. What happens when you give immunization in newborn and infancy? That's where we went into in video 2. Therefore, the questions are into that. Okay, read it.
Immune responses in early life are limited due to all of the following except.
Okay. What is that? Immune response in early life are limited due to all except.
State function.
Quick.
Limit.
See, the question is rather, often in MCQs in ours, the English is not given proper importance. Immune response in early life are limited due to all of the following except. Means all of the following limit the immune response. Maternal antibodies does, the immature immune system to a certain extent. And limited B cell response is also there. Enhanced T cell function. Is it there or not there? It is not there.
Not there.
Not there.
Yeah, okay, now I find the answer. The answer is enhanced T cell function. Now read immune response during early life immunization. Therefore, they say that last sentence, can you read?
Importantly, however, antibodies of maternal origin do not exert their inhibitory influence on infant T cell responses, which remain largely unaffected or even enhanced.
Okay, now remember they even get enhanced. Actually, the T cell responses are cell-mediated immunity is adequate even in preterm babies and newborn. It is the humoral immunity which is affected. We'll come, yeah. Can you say this now next? Can you read it? Mohsen. No, why this
Slide not came, sir.
slide didn't come. I don't know why as the slide moves forward, it becomes more and more difficult to.
Maternal IgG inhibits infant immune responses by
Okay. Yeah, slide is gone or what? Can you see this slide?
D, sir.
Huh? Maternal IgG inhibit the infant immune responses by. Give the answer first.
D.
See the maternal
D, sir.
IgG. How can it block the cytokine signaling? IgG does not have any effect on the cell-mediated immunity. Competing with infant B cell for antigen epitopes. You understand? The antigens are coming. They should stimulate the infant B cells. They will find that the antigens which the what you call the foreign antigens which are of microbes, they come in. I mean these when you give the vaccine, you will find that they will find the antibodies there, and that will be competing with the B cells for production of antibodies. Read the answer. Can you see? Read the answer. Slide has not changed or what?
Correct.
Yeah.
Competing with infant B cell for antigen epitopes.
What's the given in the bracket you read?
Slide മാറി.
By the time it becomes about 20 or 25 slides, then it doesn't change that fast. Anyway, when it changes, you read, please. Did it change?
No, sir.
Yeah.
Sir, in laptop it takes care.
Immunoglobulin G antibodies are actively transferred through the placenta
Via the follicular.
via the follicular reaction FcRn receptor from the maternal to the fetal circulation. Upon immunization, maternal antibodies bind to their specific epitopes at the antigen surface, competing with infant B cells and thus limiting B cell activation, proliferation, and differentiation.
It's simple as that. There are maternal antibodies. It is already in the newborn baby as well as in the infancy. Throughout it is there. You give a vaccine. The vaccine has to go and act on the B cells of the infant to produce antibody to that. But what happens is already the maternal antibodies are bound to these B cells, epitopes. But what happens? What is an epitope? Can anybody answer? What is an epitope? We use many words. Please, when you read anything, you refine some word, immediately Google and find out the meaning. What is epitope? We have used this word very many times. Mohsen, can you tell me what is an epitope? Epitope is a part of
Tied to where
yeah, tell me.
where the antibody binds, antigen binds.
Okay, who's answering this?
Sam Devika.
Okay, there we go. You are outshining the PRS hospital. Very good. You are a lateral entry candidate. I'm happy you're doing better. Now, the question here is epitope is the part of the antigen to which this specifically attached to. That is called the epitope. Therefore, these epitopes are already attached by the maternal antibodies. Therefore, what happens when you give a vaccine, they cannot go and stimulate it. These are primary things. Okay. Now, this is a little tough question. I didn't myself know the answer. Has the slide changed for you? If you are in the, whoever it is changed, please read it. I think it is changing in the mobile faster.
Passive transfer of, okay.
Yeah, go ahead.
Passive transfer of maternal antibodies via the placenta occurs through which receptor?
These are tough. I myself don't know the full form of all this. It's a very technical question. It seems that FCR and before if you are asked a tough question for your NEET exam, you can ask this. And this is FCRN is the placenta occurs through which receptors? Leave it now. Can you read the next question if it has changed?
Why are live attenuated vaccines more susceptible to maternal antibody interference?
Okay. Mohsen, are you there?
Yes, sir.
Yes, has the slide changed for you?
Yes, sir.
Read the ABCD, you read it first.
Why are live attenuated vaccine more susceptible to maternal antibody interference? A, they require higher doses. B, they induce weak cellular immunity. C, even small amount of passive antibodies can neutralize them. D, they are degraded rapidly in infants.
Okay. This is a very practical question. I myself was not very fully aware of it because the maternal antibodies inhibit the live viral vaccines more than the killed vaccine. This is a practical importance because we did give DPT, diphtheria, pertussis, tetanus, Hib, all kill vaccines at 6 weeks, 10 weeks, and 14 weeks. While we are worried to give measles vaccine at 9 months, we are forced to give, therefore, we give another dose at 15 months because live vaccines are more sensitive, small amounts of pass. The answer is next. Can you read the answer? Gopika, you are there?
Yes, sir.
You read.
Even small amounts of passive antibodies can neutralize them.
That's the answer. This is the next. Has it changed for you?
Yes, sir. The
Yeah.
inhibitory influence of maternal antibodies on infant B cell responses affects all vaccine types, although its influence is more marked for live attenuated viral vaccines that may be neutralized by even minute amounts of passive antibodies. Hence, antibody responses elicited in early life is short-lasting.
This is a very important point. We discussed about the maternal antibodies and its effect in full detail. I think nowhere else you'll find all points in this slide are important. We don't have time to read it. And therefore, live vaccines are more, viral vaccines are more often affected by this. Just to test the knowledge of Devika, why do you give oral polio at birth? Devika, can you answer this question? Is live vaccines are very much affected? How come you give oral polio at birth?
Don't know, sir.
Anyway, you read through the slides, you will answer. Now, next question. What happens? Shodi. Can anybody read the question? It's not changed for you?
Despite inhibition of antibody responses, maternal antibodies allow some degree of priming via
NK cell means killer cell activation. I think N is, I don't know what it means. Can anybody say that?
Natural killer cell activation.
Natural killer cell activation. Number 2 is yes, which is the answer? Gopika, Mohsin. Can you give the answer? No? Is it so difficult? I'll give you the answer then. What's the answer?
Memory B cell induction.
Yeah, memory B cell induction. Gopika, that last time we discussed about neonatal and newborn and infant immunology. Can you just summarize what is the? I mean, if I go into that, I will be spending too much time onto this. We won't be answering it. I'm a little disappointed that you're not answering so fast in spite of me emphasizing and teaching. Please remember that in newborn period, the antigen protection, once it enters the germinal center, the antibodies are produced in very high concentration. That is called secondary immune response, IgG, clone-specific antibodies. Along with that, memory cells are also produced, which go into the blood and come into the periphery of the lymph node and the spleen and remain there as memory cells. Now, in the newborn period, the response of producing high level of IgG antibodies is not very good. But at the same time, the memory cells are produced. But what does it mean? The next time it is ready, or in other words, the first dose you give may not produce high antibodies, but it primes it. This is called priming. Now you come to the next slide. I think it is there, the last response. Gopika, you read the last line.
However, even during early life, induction of B memory cells is not limited, which is mediated through T helper cells. The extent and duration of the inhibitory influence of maternal antibodies increase with gestational age, example with the amount of transferred immunoglobulins, and decline with postnatal age as maternal antibodies wane.
Okay, the most important thing you should remember that though the antibody the production is decreased, memory B cells are produced, and these memory B cells are there ready for action when next time you give. This action or the first dose you give is for priming. This is what you call, why do you give oral polio? Priming. Why do you give hepatitis B first vaccine? Again, priming. Even the DPT first dose is mainly for priming, so that the second dose, the memory cells come into being. Okay. Govika, you read it. Now, people in the library, it is not changing for you in the laptop. Mohsen?
Taking time, sir.
How
It take time, sir. Now showing that slide on immune response during early life.
And there's a problem. Now, I think what you should do is you should also log in through your phone along with the laptop. Okay. And keep it in mute.
Okay.
So that you know what is a slide that is coming up. Because if we wait for to change, too much time is going. In the library also, you log in through maybe the net is slow there. I'm not too sure about it. Okay, can you read the 17th slide now, Mohsen? 17, number 17. It's not changed?
Yes, sir. Infant B cell responses to polysaccharide antigens are limited during the first 2 years of life due to all of the following, except
Increased T cell.
Yeah, increased T cell help. That's the answer. Increased T cell help. And Gobika, you can read the slide. Now it has come up, the answer. Can you read it, Gobika?
So answer is increased T cell health.
Yeah. And has it changed now to the next slide?
Slide not changed, sir. Yes, sir. Now it changed.
Okay.
Early life immune responses are characterized by age-dependent limitations of the magnitude of responses to all vaccines. Antibody responses to most polysaccharide antigens are not elicited during the first 2 years of life, which is likely to reflect numerous factors, including the slow maturation of the spleen marginal zone, limited expression of CD21 on B cells, and limited availability of the complement factors.
Therefore, you can be asked a full question on immunology of newborn. You understand? See, when you go for a DNB exam or when you go for your DCH exam, definitely they will not ask you what is immunization schedule. That's an undergraduate question. Therefore, they will have to up the grade to a DCH and especially to DNB. Even during our MD examination, the commonest question we expected was immunology of newborn and infancy, and how do they affect the immunization in the infancy. That's a very important topic. We had discussed in full detail, slide by slide. The purple books gives well, but wherever there was some problem, I took it from Potkins, which is an authority on vaccine, which is about it contains about 5,000 or 8,000 pages, and also I have taken from the Nelson's textbook of Pediatrics 24 and summarized it and put it in slide. Each one of it is very important. Therefore, these are the reasons. Therefore, you should know the fundamentals of it. Okay, now next slide.
Glycoconjugate vaccines may still elicit lower IgG responses in young infants due to all of the
Yeah. See, the glycoconjugate proteins, which we are giving DPT, etc., triple, what you call diphtheria, pertussis, tetanus, hepatitis B, we conjugate it with proteins and give it at 6, 10, and 14 weeks. Even that will elicit lower than in an older child. That's why we give a booster at 1.5 years. We want the antibody in young age, otherwise the infant will get disease. Because of all these are problems in the infancy, high maternal antibodies, poor APC means what? Antigen presenting cell function, immaturity of the germinal centers. All of the above will be the answer. Okay. Now the slide changes. Please, whoever sees the slide first, read the answer.
Although this may be circumvented in part by the use of glycoconjugate vaccines, even the most potent glycoconjugate vaccines elicit markedly lower primary IgG responses in young infants.
Okay, that is the thing. Mohsin and Majida, have you logged in with your phone?
Yes, sir.
Okay.
Yes.
The way you should be able to read as soon as the slide changes now. Can you read the next slide if it has changed? These are tough questions a little. Goes a little too deep into the immunology, but for people, especially for DCH, I know that for a DNB, you're not going to have an MCQ. Okay, now read it.
Which process allows for affinity
Which process
maturation
allows
of B
for
cells?
affinity maturation?
Yeah, read most of me, read. Okay, go ahead. One of you. What happened? Hello? Are you there?
Which process allows for affinity maturation of B cells even in the first year of life?
Okay. Allows for affinity maturation of this is a little tough question. Can you answer? It is somatic hypermutation. Okay. Somatic hypermutation. I don't know whether it's required. Can you read the answer if it has changed?
Vaccine response at the extremes of age, the challenges of neonatal and early life immunization, isotype switching, and somatic hypermutation, that is, the affinity maturation of vaccine induced B cells, are already functional in the first year of life, including in preterm infants.
Okay. Therefore, even in preterm vaccination, you can give vaccination possible. Devika, in your hospital, how do they give the immunization? Do they give it for preterm in the nursery? You are still there?
Yes, sir. Uh,
Do they-
we have just joined and we are not posted to NICU, so
Very
I
good.
don't know much about
Okay,
the policy
Gopika,
here. But otherwise,
yeah, otherwise,
otherwise we do give. But except for hepatitis B, we usually never used to give in government setup for less than 2 kgs initially because of the low muscle mass. But otherwise, all in vaccines are given.
which government sector did you work?
I was working in health service, sir.
Where?
Nedumangad
And they don't give
District
for
Hospital.
less than 2 kg, they don't give.
Yeah, because of muscle less than 1.5 kg. Sorry, sir.
Gopika, is it that way? True in our hospital? Gopika?
Yes, sir. That
When do you give a newborn baby a hepatitis B vaccine? It's a very important question. Therefore, I'm just asking you a very important point.
Ideally, it is not mandatory
Uh,
not to give, but it was a policy which was followed. It is not necessary that we should not give for less than 1.5 kg. But if the mother is hepatitis B positive, we do give.
okay, therefore you do it. So there can be mothers who we don't know the status. Am I right? There can be mothers.
No, sir, the thing is, it is not mandatory not to give, even if the baby has low birth weight. We can give.
My question is it mandatory to give? Gopika, can you answer that question?
To give.
These are fundamental things which you should know in immunization. I am stopping this presentation here and asking you this question because you are the final question. It's a very important question. It can become legal also. Okay.
yes, sir. We should give hepatitis vaccine if the mother is positive.
Negative. Now, of course, you know that you are working in PRS hospital. You have the mothers are always screened, everything I know, but there can be mothers who came without booking. You go to a health center, am I right, Devika? There will be many mothers who are not booked. They will come and deliver. In Kerala, maybe
Yes,
it
sir.
is less. In most of the
Yes,
hospitals, they
yes.
deliver at home and come. Therefore, to these mothers, is it very important to give hepatitis B
Yes,
early, or
yes,
can
sir.
you postpone it?
No, it is better to give, sir.
Yeah, why is it better to give? What's the reason why you give hepatitis B at birth? Why is it B, sir? How fast? I mean, suppose a baby is 3 kg, how fast should you be giving the hepatitis B vaccine? We might be discussing this again in hepatitis B, but I want, maybe all of you will not attend that class, or some of you might sleep through the class also. Therefore, these things are here. Therefore, my question here is very simple. Why are you giving hepatitis B at birth? To my
So,
best,
to prevent the perinatal transmission, sir.
yeah. Why are you so interested in perinatal transmission? You get a needle prick. You might wait for some time before you give. Here we are supposed to give within 24 hours, and 24 hours is a giving hepatitis B before discharge from the hospital. Before 24 hours is considered one of the ways in which the efficiency of a vaccination in a hospital is judged. Even on a weekend, you should give. If the patient goes lama means against medical advice in the middle of the night, you should give the vaccine and send. Why are you so concerned about it? Because you want perinatal transmission to be stopped. Why do you want perinatal transmission to be stopped? Because whenever there is perinatal transmission, the risk of it being a persistent carrier is very much higher. I am not able to tell the percentage. If you get a needle prick, the chances of you becoming a persistent carrier may be in a single digit, but otherwise it is in very high digit. More important than that, they say if the mother to the child transfers the maternal transfers the hepatitis B, there is 30% chance of hepatic carcinoma. Therefore, that is why you should give. To the best of my knowledge, you should give for even preterm. Maybe for babies who are less than 2 kg, it is not considered as a newborn vaccination. You may again give it. See, normally in Western countries, they give only 3 doses. They will give 4 doses. That is at 0, 6 weeks, and 6 months. We will come to that later. Therefore, anyway, that we sidestep to preterm immunization. I stopped it because hepatitis B is a very important thing. And I don't think it is absolutely right to not to give for a child less than 2 kg. No, you have to give it. And if you don't give it, and if the child develops a positive hepatitis B, becomes positive later, they can sue you for that. This happened where I was working in the Gulf. One of my pediatricians got into trouble because he did not give for some other reason, and then he got into severe problems. Okay, remember next. Can you read it?
Neonatal T cell responses are characterized by
Maybe a little tough. You can give you the answer straight away. One thing I understand is now I presented the slides. I sent you the slides through the thing. You have not gone through it. Anyway, these may not be very important, but it is better to know it. What's the... Can you read the answer?
predominant T helper cell 2 and T helper cell 17 responses.
Read the explanation.
Neonatal and infant T cell responses also differ from those elicited later in life, in particular in the induction of lower interferon gamma and higher T helper cell 2 and or T helper cell 17 responses.
Yeah, because there is an higher TH2. There we want TH1 actually. There's a difference in the immunity response. May not be important because I put it up from the Plotkins vaccine. It's a higher immunology is involved. Maybe your examiner may not be aware of it, therefore you can escape. Okay, now comes the question.
BCG vaccination at birth induces a strong
BCG vaccination, immunology is very, very important. Okay. Devika, can you tell me?
BCG vaccination growth induces a strong.
Well, we want TH1 and TH17 response. Instead of a newborn, normally it induces TH2, which is not very good. But BCG specifically induces TH1. Okay, this is given in the purple book. Okay. Let me tell you one thing. In immunology, if they are in immunization, if they ask you any questions from the purple book, more important, WHO position papers, World Health Organization position papers, Google it. For every vaccine there is there. Sometimes there will be PDF formula slides, but they have a beautiful write-up. You have to read it. You are not a pediatrician if you are not written a WHO position paper. Gopika, can you tell me what is WHO position? Why do they call it position paper? Any idea? Why don't they call it WHO immunization website or something? Mohsen, you are doing some Majida, can you tell me, all of you are DNB students, huh? You are real postgraduate students. Immunology you should be knowing well. Why does the WHO call it position papers? What do you mean by position papers? Gopika, have you ever seen that?
Yes, sir.
Yeah. Why do they call it position papers?
Each year the updates will come.
Yeah, then it should be called WHO updated immunization schedule. Why she's writing position papers? In 1962, when I was probably 8 years old or something, the immunization schedule was put up by WHO. That immunization schedule is a schedule which changed the way we live. Smallpox was eradicated, BCG was there. So many. It is really something which goes into history books of human beings. But they went on giving the immunization schedule till 1997 or something. Then they said, okay, we can't give the immunization schedule to all the countries. The countries have to adopt their own immunization schedule. And what we give you is advice, the position what we hold. For example, the position which in human papilloma virus, the WHO position is all countries should adopt it. But India is not having, because India can have only if they have money and they are able to produce it. Therefore, now the WHO says what is its position, whether developing countries should do it, whether they should give the booster dose at what age, everything. It is up to the individual countries to have their own immunization schedule, customizing it. India customizes it very much. Certain countries like Oman, where I work, they simply copy and paste what WHO says. But here, it's a good thing we discuss, we find out what age it should. For example, 6, 10, and 14 weeks immunization is advised by WHO. We have accepted it. Okay. The WHOs may say many other things which we may not accept. For example, in human papilloma virus, they are telling that a single dose is enough, but we don't accept it so far. Therefore, so many things are there. In India, it goes through 3 stages. We look at this WHO and CDC, then the IAP does something. What the IAP says has a tremendous effect on the private practice. But in government services, universal immunization with the government decides. Government may be taking the opinion of IAP, I doubt it. Now, BCG vaccine induces a strong Th1 response. Go through it. Sorry, yeah. See, we read has the slide changed for you? Has it become blue for anybody? You can start reading. Hello, are you there?
Remarkably, adult-like Th1 neonatal responses are notoriously elicited by BCG.
I don't know why they added notoriously. In the previous line, you yourself read it. Neonatal and infant cell responses also differ from elicit later in life. Induction of lower IFN gamma, that is interferon nuclear gamma, and higher Th2 and Th17 responses. We want Th1 response is better, and Th1 is elicited by the BCG. That's other antigens, other the vaccines, they produce Th2, which is not very good for the vaccine, but Th1 is elicited by the BCG. Okay, now go ahead.
To overcome maternal antibody inhibition, one strategy is to
Well, all this we discussed. When I put up these MCQs, I did not give the explanation because I thought that you would be answering very fast. See, you must use your common sense and your experience. To overcome maternal antibody, one strategy, delay vaccine, is a stupid answer. You will not use. Use live vaccine only. Stupid answer because we are using kill. And administer intradermally. Stupid answer. We are not doing it. Therefore, the only thing that comes to some this increased vaccine antigen dose. That's the only thing which comes common sense. When you answer MCQs, especially when you have only one answer, you should look at the others also and rule out certain things and finally come into answer, even if you don't know specifically the answer. Therefore, the answer is increased vaccine antigen dose. Now, the explanation, the blue slide, can anybody read if it has changed? To whoever it has changed, please read it immediately. What I bracketed.
Increase the dose of vaccine antigen may be sufficient to circumvent the inhibitory influence of maternal antibodies, as illustrated for hepatitis A, measles, and the higher content of pertussis toxin in acellular versus whole cell pertussis vaccines.
Okay, this is, remember that whole cell pertussis vaccine is supposed to be superior, but in this way, because they have increased the cell content very much in acellular vaccine, the inhibitory of the maternal antibodies, but maybe much less. The next line is, however, the higher titers of maternal antibodies elicited by maternal immunization eventually interfere even with responses to acellular pertussis vaccine. That is the answer to it. And therefore, the maternal antibodies. Now, I may ask you the slide change. By the time the slide change, I will ask you a question. What is the time interval we are giving at 6, 10, and 14 weeks? The dosage of immunization in our country. How do they give it in UK or USA, Dr. Devika? Any idea?
No, sir.
No idea. The Gopika, can you tell me? How do they give it in the Gulf? Mohsin, how do they give it in the Gulf? Any idea
Which
what's the
vaccine, sir?
dosage schedule, initial dosage schedule? We give 6, 10, and 14 weeks. How do they give it in the Western country? Like USA?
One for
Huh?
second.
What's it?
After birth dose, it will come after birth dose, then by month,
What months?
second.
Yeah. Second 4 and 6
second
months.
month.
2, 4, and 6 months.
Yes.
But we give it at 6 weeks, which is 1 month and 2 weeks. We give it earlier. Developing countries, WHO says give it earlier because you may have diphtheria, pertussis, tetanus coming up at a younger age, especially pertussis. Therefore, we want. Therefore, it is a trade-off between maternal inhibition as well as the diseases which we have in our country. Therefore, because our immunization status has increased, the effectiveness will be much later if you delay the immunization. If you delay it, the maternal antibody inhibition will become less. Therefore, in Western countries, they have found they can delay the first dose up to the second month. That is 8 weeks. And there's another advantage also, that which we come to that later. We have come to hello, yes?
Excuse me, sir.
Yeah.
Sir, Devika here. Sir, I'm on duty and I've got a call. Shall I leave
Yeah, you're fully
for the
allowed.
time being?
Okay, thank
Thanks.
you. Thanks
Thank
for
you
the
so much, sir.
Okay,
Thank
bye.
you so much.
Well, she was the particular, I don't want to name the hospital from which she is coming. She requested me to involve her, therefore I have involved her. Therefore, her enthusiasm is very much appreciated. Now, to you, therefore, we give it 2 and 4 and 6 months because the inhibitory effect will not be will be less. But it may be too late for some of the disease in children. That's why the immunization schedule, lot of basic science goes into it. Now, Mohsen, read what is the slide you see.
Increasing the number of vaccine doses in infancy helps by enhancing memory based recruitment.
Increasing the number of doses of the same vaccine, you understand? Okay, same vaccine. How does it act? Enhancing memory B-cell. I think you're right. Yeah, you can read it. How do you read? The slide has changed.
Enhancing memory based recruitment.
Yeah.
No, sir.
Yeah, the answer is B only, enhancing memory B-cell.
Immune response during early life immunization. limitation of young age immunization. Continue.
Yeah.
Slide.
ഇപ്പൊ വരും ഒന്നുകൂടെ വരും because I changed it back. Change ചെയ്തോ?
Yes.
Yeah.
Limitations of young age immunization can be countered to a certain extent by increasing the number of vaccine doses for better induction, use of adjuvants to improve immunogenicity of vaccines, and by use of boosters at a later age when immune system has shown more maturity than at time of induction.
Okay, we have gone through it. I think we have gone through it several times. Can you read the answer? Give.
For killed vaccine like DPT, the first dose act as priming dose.
Okay, priming dose. Very good.
Priming.
Priming means it stimulates the memory cells. Okay, you're right. The next question.
A booster dose at 15 to 18 months is required for durable immunity with vaccines such as
Is required for durable immunity. You must read the stem cells very well. And I would say, where is Faris today?
So he is leave, sir. He went to IIT. His brother's convocation.
His brother's convocation.
Today's brother convocation. IIT Madras.
Oh, he's doing IIT. What is he doing there? BTech, very good. His brother is an IIT graduate. Huh? Great. But Faris has very much to improve that. Okay. Yeah, booster dose at 15 to 18 months is required for durable immunity with vaccines such as. Every sentence is important. Here, we are not giving BCG or OPB at 15 to 18 months. May not be the answer. The question is between Hib pneumococcal and MMR. Both we are giving at that time. Well, if you have answered my class, why are you giving a booster dose of MMR? It's a live vaccine.
Low, if first one, if it's not.
Yeah, but if the first one doesn't take, what you call as primary vaccine failure. Okay, if the first one did not take at all because of antibody, actually, we never talk of primary vaccine failure for parental injections. But in this immunology textbook, they started talking. This was mainly the reason for oral polio. Oral polio, we give 5 doses, 7 doses, because you think that the previous dose may not have been taken up. One vaccine, live vaccine taken up, it produces a primary, secondary response that is enough for life. It mimics a natural infection. Therefore, if you get a natural infection with a particular type of pneumococcal strain, it should produce lifelong immunity. I mean, if it is with the measles or mumps, it will not come back again. Mumps is very unlikely that you will get a second attack of mumps. Now, therefore, here the question is a booster dose required for durable immunity with vaccine. That means even if you are given the first vaccine and it produces immunity, for the immunity to continue, that is for killed vaccines. Okay. Therefore, this is therefore Hib and pneumococcal vaccine. Remember in your MCQ, remember read the stem carefully. Look at that. You can just, when you have the multiple choices, certain things can go out of the immediately. Then 2 things will come into play, Hib or pneumococcal or MMR. Go back to the stem and read it carefully. It is not, the wording is important. Therefore, English knowledge is also important in these things. Okay, what's the explanation? Anybody?
Not changed, sir.
Are you seeing it in your this one also? See, when you're changing, I would like to tell you one thing. The enthusiasm from your side is rather discouraging for me. People who are going home can very well, if you are on leave, you can very well focus. I don't think you will get such classes. People from outside the hospital are requesting for them to come in. and I'm allowing them when their consultants also agree for it. Otherwise, I don't agree for that. Therefore, now from your own hospital, if you don't log in at exactly at 4 o'clock or 3 o'clock, and today, how many people are there? Only one, Mohsin, Gopika, Majida, and only 3 people. Am I right? Lasima has not come. Ashwati has not come. Where is Ashwati?
Ashwati joined actually, sir. She left time.
Where is she? At home?
She had duty yesterday, so she went home.
Yeah, at home she should join, and you don't go through the
You
slides
join.
when I put it up in the when, YouTube also, and that is very clear from the answers you're giving. Anyway, now read the slide which is given.
Vaccination schedule for killed vaccines such as DPT, hib, pneumococcal, and hepatitis B, which are administered as early as birth or 6 weeks. The first dose act only as a priming dose, while subsequent doses provide an immune response even in presence of maternal antibodies. However, the booster at 15 to 18 months is required for durable immunity.
See, what he says is the first dose acts as a priming. Actually, now let's go into this slide, very important slide. I hope I will explain to you in a little way. I had told that's one of the most important slides put up by the very good slides put up. You see can you see the slide? Has it changed for you?
Same slides.
Yeah. I want
Yes,
to,
diagram, sir.
yeah, diagram. Has it come?
Graph.
Yeah, well, now I will explain it to
Okay.
you. See, the bottom of it, you will find schematic presentation of various components of 0, 1, and 6 months immunization schedule. Now, if you want to give kid the vaccine, the best schedule in the world is 0, that is at the time at first day. 1 month is actually 6 weeks. They are giving 1 month and 6 months. 3 doses are enough. That's why if you find somebody has not taken hepatitis B, you want to give catch-up immunization, the best to give is 0, 1, and 6
0.
months. But instead of it, what are we doing? Now I will come into that. When you give the first the vaccine enters the cell, that enters the cells, sees the B cell, and the B cell, B cell has to enter the germinal center, for which it takes the help of the T cell. Once it enters the T cell, it has follicular dendricular cells, the T helper cells. The B cells go into proliferation. They produce plasma cells and produce high level of antibody. Okay. And that's what it happens. And some of them come back into as memory cells. Some of them go into the bone marrow and remain there. Therefore, the most important thing is that in the first 2 doses is induction. Actually, the DPT, why are we giving 6, 10, 14 weeks? This is because we think that the maternal antibodies may affect. The priming dose is done by the 6 weeks. The 10th and the 14th week, one at least will act as a induction of the vaccine. But even then, the memory B cells are not reactivated because in the germinal center, it may take 4 to 6 months. So, for 1 to 2 dose for induction, affinity maturation, clonal selection of the fittest B cell, 4 to 6 weeks. And after 4 to 6 weeks, only if you give, the memory B cell reactivate by a booster dose. Therefore, first 2 doses you can give within 6 months. More than 4 to 6 months it takes for the affinity maturation. Therefore, the booster dose should at least be 6 months away from the primary dose. Better not to be in the infancy, better to be beyond infancy. But in certain doses, we are giving the booster dose at 9 months. 9 months also you can give, but it will not be as effective as in the 1.5 years. Mohsen, what is the medicine for which we give the final dose at 9 months in our immunization schedule?
Yeah.
Which vaccine in our immunization schedule will give the last dose of the booster dose at 9 months?
IPV, you give, sir.
IPB, you give
9
it
months,
9
sir.
months. Gopika,
No, sir. Mr. No. PC.
BCG is the last dose. You give 3 doses. The last dose is given 9 months in the government sector. Am I to understand that you don't know the immunization schedule of children who are given in the government sector right now?
PC booster also.
Which one?
PCV booster.
Very good. What is the regimen that is given in PCV?
6 and 10.
14.
14 and 9.
Yeah, 6, 14, and 9 months. Why I'm asking you is I'm giving you some very critical things in this, because some patients may come and ask you, doctor, the same vaccine is given in government sector. Here you are charging 5,000, 8,000 rupees. Should I come to you? Now, the best answer to give them is, it's up to you if you're not your private patient. But if you're patient, you have very good conformity, you can say many things, because some of the things which we are not very happy, but in the universal immunization program, they have to give it is at 9 months is they don't want to make frequent visits, and they don't want to wait. They don't have too much money to give 4 doses. Therefore, they are giving only 3 doses. When they are giving 3 doses, they are giving at 6, 14, and 9 months. Why don't they give it at 1.5 years? They are worried that just 2 doses, it may not have enough antibody. You may get a pneumococcal pneumonia at 8 months. Therefore, at 9 months, they are giving. Approved by WHO. But please remember, long-lasting immunity unlikely to be present when you give it 9 months, as much as when you give it at 1.5 years. Therefore, in our practice, what we do, 6, 10, 14 weeks, they are giving in PRS hospital, and they're giving a booster at 15. The 3+1 regime is definitely superior to 2+1 regime. And this is very clearly written in IAP. Therefore, read through this, what I've given in the highlight in the yellow. Can you read it?
Yes.
Yeah, read it.
Traditionally, 0-1-6 month schedule, that is prime and boost, is considered as a more immunogenic schedule than 6, 10, 14 weeks or 2, 3, 5 months or 2, 4, 6 month schedules for non-live T cell dependent vaccines such as hepatitis B vaccine.
Then why in the hell don't you give it like that way? But tomorrow, where is Amal, by the way?
PICU, sir.
Why doesn't he join? PIC, what is he doing there? There seems not to be very much enthusiasm from your side. Now, tell me, why don't you? Now, when I ask you fundamental question, I wanted to finish this. I'm just out of 91 slides, I have just finished 46, and already time is almost 4:30. But we won't be finishing even the MCQs this time. Well, now tell me, 0-1-6 months is the best. Then why don't you give it that way? Why do you want to give it as 6 weeks, 10 weeks, 14 weeks, and even in the West, they are giving 2, 3, and 5 months, 2, 4, and 6 months. The best immunization schedule immunologically is 6 weeks, and 6 months, or 1 month, and 6 months. That's what is given from this diagram. The first dose, 1 or 2 doses acts here. The second dose acts this by induction. It waits for 6 months for the affinity maturation clonal, and then you give the booster. Okay, reactivation by a booster. These are for induction. 0 and 1 month is induction, and then this is by the booster at 6 months. Then why are we giving it 6 weeks, 10 weeks, 14 weeks, 3 doses, and not giving it the 6 month? And why are we Western countries also giving 3 doses for induction? Gopika,
Cases increases.
what's it? The answer is, when we tell a patient, you please come today, you come after 6 weeks, you come after 6 months, the compliance is very much less. That is the reason. If you have to tell, come next month, they will come. But if you say, come after 6 weeks, unless he has a Google Calendar, she may not come. Therefore, the compliance become less. Then 2 doses are required, enough for, if it is apart by about 8 weeks is enough actually. But what we are doing, we are giving an extra dose so that because we are giving every month, the second dose may not act as effective. In case one of them doesn't work, we give 3 doses. And further, the booster, we postpone it to 1.5 years in most of the vaccines, is it not? Therefore, we expect that 12 weeks, 6, 10, and 14 weeks, the 14 weeks to act as a booster also to a certain extent. But why don't you give it at 6 months, the booster? Because it is not as effective. The antibodies don't last as long as the other. But the best schedule, if you have a tetanus today, the child comes to you with an injury. He is not as a mild injury. He has not taken tetanus vaccine. The best schedule for a catch-up immunization, 0, 1, 6 months. That gives you idea. Very minimum doses, the best immunological response. Okay, now come to the next question.
Measles vaccine given at 6 months primarily induces interferon CD4. Interferon gamma produces CD4.
Yeah, very good. Interferon gamma. Do you give measles at 6 months, Majida?
9 months. 9 months.
Then why do you say 6 months? Mohsen, will you give it any time, 6 months?
No.
Up to that, antibody is a maternal antibody.
No. Will you give it at 6 months? Will you ever give a child measles vaccine at 6 months?
If the case plays,
yeah. Go on.
If the place is endemic to measles, means you can give up to 6 months.
Endemic. Okay.
Or outbreak is more than.
Yeah, when there is an epidemic. When there is an epidemic, you can give it at 6 months, but you don't count it. You again give it 9 months, you again give it 1.5 years. Okay. When there is an epidemic, you may give a meningococcal vaccine at 1 year. Maybe someplace I found even 3 months. Not that effective, not very effective, but still you will give. When there's an epidemic of viral hepatitis, normally you give it 1.5 years, you give it 12 months. For everything, there is a lower limit which you can give it during an epidemic. Again, medico-legal significance. You see a child with measles, you diagnose as a measles, you give a very good treatment. The child survives. The child is 4 years old. You never ask, do you have a younger infant? You may have an infant which is 6 months or 7 months. The child wouldn't have taken measles vaccine because he's not old enough. And you also did not know. The younger the life, what happens when they develop measles, it becomes more severe. They can die, morbidity and mortality is high. The child dies. The mother can see you and tell you, look, I took the elder child, they took the family history, they knew that there was a child 8 months, they did not give immunization. Remember, these will be the facts which will come to haunt you when you start practicing. When we have gone through all this. Nothing happened to us. We have made huge mistakes in the bad. I myself has made. But I never thought it was a mistake. These things do happen, but it cannot continue. Remember this. Everything has got medico-legal significance. If you have a child with measles, ask immediately whether you have a younger child. If you have a younger child above 6 months, give him the measles vaccine and tell them this is absolutely important. Okay. The measles vaccine, it seems interferon gamma. I was a little surprised at this. Look at the answer. Yeah.
Interferon.
As a slight change for you. Last one, the green one, it must have come as green. So remember that every word we discuss here, it has got practical importance. It may come to you after 30 years of your practice. You cannot say that I didn't know it. No. Here I heard that some newborn baby was given a local anesthesia and the child died. And the doctor is telling that the mother never told me that the child was preterm. It is up to you to take a family history. You understand? In our examination, history taking is a part, and history taking family, the past history is very important. Now read it. It must have changed in your side. Last sentence.
Vaccination schedule continue.
Yeah.
For vaccines such as DPT, hip, pneumococcal, and hepatitis B, which are administered as early as birth, 6 weeks, the first dose act only as a priming dose.
I mean, forget it.
While
Read the last one,
dose,
last sentence, which I've highlighted.
furthermore, measles vaccine, if given at the age of 6 months, in an outbreak situation, may work by inducing T cell immunity.
Yeah. Therefore, that's the question. May function by increasing T cell immunity, inducing T cell immunity, and direct causing CD8 T cell destruction. That is, intracellular pathogens are destroyed. Viruses and intracellular pathogens, CD8 killer cells it will produce, and it may also ask as a priming dose. For whatever it is, you are supposed to give by 6 months in an epidemic. Remember this. Okay. Has it changed?
The recommended schedule for hepatitis B vaccine in developing countries is often 6 to 14. Hepatitis B vaccine.
In developing country, what is the dose advised?
6, 10,
Remember, the recommended schedule is immunization schedule. Okay. Therefore, you should go through it. Your doubt will be 0, 1, and 6 months. I emphasize this too much. But the recommended schedule is 6, 10, and 14 weeks. We told you already. Schedule is different from, okay? Hello? Yeah.
Sir.
Can you read this?
Answer is
Correct
B.
answer B. 6,
correct
10,
answer
14
B.
weeks.
Now, let me ask you one question here. Is there any problem of hepatitis? I will ask you a hepatitis B vaccine. We might discuss it again, but I would spend some time on hepatitis B immunization, especially the schedule which we are giving. Is there any issue in the schedule which we are giving? How do we give in the private sector? We give a dose in PRS hospital.
One more dose. 0 dose is same.
And then what are the doses?
6, 10, 14.
Yeah. Then?
And one more dose.
Then?
But, 15, 16.
I am asking you. Huh? Now I'll just
15,
pause here. Maybe
16.
this will be the final slide I discuss because it's very important. I thought this has gone through in your mind, but the way you are answering questions.
IAP, one more dose is there.
When?
15, 16 months.
Amal has joined.
Amal came here right now. He passed theory.
Practical, no? He went for
Theory
practical.
exam result.
Congratulations, Amal.
Practical is still.
I thought if what's it? Amal, did you pass your theory? You passed.
Theory theory one, sir. Any practical and
Practical. Okay. All the. What happened to Dr. He is not responding at all. Our Srinath. Is he? What happened to his admission?
ഇപ്പൊ join ചെയ്യുന്നില്ലെന്ന് പറഞ്ഞു.
Next time.
Why?
വൈഫ് കൂടി എവിടെയെങ്കിലും കയറിയിട്ട് ജോയിൻ ചെയ്യാനായിട്ട്.
Well, it's not a very good decision, to tell you the truth. Yeah. He never asked me that question because I would have been cross with him. You should have joined immediately because it is like maternal antibodies. Your knowledge level will decrease very fast in the next 1 year. Momentum you have used to study the DCH, you should use it to pass your DNB also. Never postpone it. Never postpone it. Anyway, now the immunization hepatitis B vaccine is 6, 10, and 14 weeks. Now I would like to ask you certain things here. See, is there a booster dose for hepatitis B advised by the IAP, by the CDC at 1.5 years?
Yes.
Yes, sir.
They are at what age? What age are they advising the booster?
15, 16 months.
What's it? When is the booster dose of hepatitis B
15
advised?
months.
1.5 years. Now in 2025, I am showing you the immunization. Is there a diagram which is given in the CDC table which has come up for you? Slide. Table 1. Has it come?
Yes, sir.
Okay. Now I would like to look for you. I look at the pointer. I'll go very slow here. I want to drive home some point here. That's why. Now look at this is recommended child and adolescent immunization schedule for 18 years in the United States 2025. Okay. Schedule. Hepatitis B vaccination. First dose, second dose. Okay. First dose at birth. Second dose from 1 month, from 4 weeks to 8 weeks. They give it at 2 months. At the end of 2 months, they give. Third dose from 6 months to 18 months. Normally they give it at 6 months. Okay. This is the range for normal children, immunocompetent children. Okay. There are only 3 doses. If they give it at 6 months, there is no booster. You understand? Okay. Okay, that? Did you follow that?
So,
Okay. Now let's read. Has the yellow slide come up for you? Yellow marks. Routine series, has it come? Okay.
Yes, sir.
Okay. Now read it carefully. Don't tell me you don't know this. You don't know this about this again. Read that very carefully from the beginning.
3-dose series at 0, 1 to 2, or 6 to 18 months. Use monovalent hepatitis B vaccine for doses administered before age 6 weeks.
There was 0, 1 to
Infants
2
who
months.
did not
Yeah. Okay. Go ahead.
0, 1 to 2, 3. Infants who did not receive a birth dose should begin the series as soon as feasible. Administration of 4 doses is permitted when a combination vaccine containing hepatitis B used after the birth dose. Minimum age for the final 3rd or 4th dose is 24 weeks, and the minimum interval dose 1 to 2 dose
4 weeks.
so 4 weeks, dose 2 to dose 3 8 weeks, dose 1 to dose 3 16 weeks. When 4 doses are administered, substitute dose 4 for dose 3 in these calculations.
Now my question to you: in our hospital, how many doses do we administer?
4 doses.
4 doses?
Birth dose including birth.
Including birth dose, how many doses do we administer, Gopika? Hepatitis. Huh?
5 doses.
5
doses.
We are giving 5 doses. Amal is very good. Your theory, very good. Okay. They are saying 4 doses may be administered, but we are administering 5 doses. So we'll come to that later. Therefore, remember one thing. I have written one thing. I have highlighted one thing in red. What is it?
Minimum age for the final dose 24 weeks.
24
That is
weeks. The
3rd or
last
4th.
dose, 3rd or 4th should be 24 weeks, 6 months. You should not give before that. There's many other things. The first dose and second dose should be separated by 4 weeks. And they also say that dose 1 to 2 dose 4 weeks, 2 to 3 should be 8 weeks, and 1 to 3 should be 16 weeks. If it is 4 doses, then you can substitute the third dose to 4. Therefore, this is the schedule which is advised. But the most important thing is the last dose should be given at 6 months. How do they give it? Now I changed the vaccine. Have you seen has it changed for you? This is the
Yes,
current
sir.
national immunization schedule. Now I want you to see when is what do you call see, you are giving at 6 weeks, you are giving hepatitis B. All right, can you see it? 10 weeks, you are giving
Yes, sir.
hepatitis B as pentavalent vaccine. 14 weeks, you are giving hepatitis B. Class, where are we giving any time? At any time are we giving hepatitis B? But what's the problem with this immunization schedule in the current immunization national immunization schedule? According to IAP, I just told you something. There are deficiencies in the immunization schedule in the government sector. One of this is hepatitis B. What's the problem here? The last dose is not given in 6 months. It is given at 4 weeks, means it is 3 months and 2 weeks. Is it not? Right?
Yes.
3 months and 2 weeks. Why are we so insistent that we give the last dose at 6 months and not at 4 weeks and 2 months? Because we are not giving a booster. You understand? We are not giving a booster for hepatitis B. Why are we not giving a booster for real booster? We are not giving the booster. The dose we are giving at 6 months is actually the booster for hepatitis B. Now, why are we not giving a booster for hepatitis B? Because for the principle in immunization is give the minimum number of doses that is required. Because you are giving it's not like giving antibiotics. Remember that. You are giving an antigen or a medical matter to a child who is absolutely normal. Therefore, you have no right. It is not like giving antibiotic which you give for a sick child. Instead of 5 days, you may give 7 days. That's okay. But for a sick, new normal child, you are not supposed to give any antigen which is not necessary. It has been proved beyond doubt that if you give 0, 1 month, and 6 months, hepatitis B, 30 years they have been immunizing, there is no failure. This is because hepatitis B has a long incubation period. Once the memory cells are there, for me, I think the incubation period is somewhere between 50 to 150 days. The memory cells will produce enough antibodies, and therefore you are not giving booster dose. Remember, protection from hepatitis B is very necessary, not only in newborn, in adolescents, in adults also, because that's when you get pinpricks, you can get it through sexual contact, etc. Therefore, hepatitis B, though it protection lifelong, is very important. No boosters are given at 1.5 years, because the principle in immunization is for every dose you give, there should be a theoretical basis. Now let's look. Therefore, there's a big problem in the national immunization schedule. They are not giving the final dose at 6 months. Neither are they giving the boosters. Therefore, if any one of your relatives have taken immunization from hepatitis B, from the government sector, there is a problem in that. Now, that's over. Now look at it. Has it moved for you? Can you read what I have written in red? Has it changed?
Last dose.
Yeah.
No,
This is
not
a very
changed, sir.
important point. Yeah, read.
Last dose not given and minimum interval between last 2 doses not 8 weeks, and the first and last dose is not 16 weeks. It's 4 months.
Therefore, there's a huge gap. There's a huge problem in the immunization schedule which they brought in hepatitis B. If you go to any IAP conference, any immunization clinic, stand up and ask, they will not answer this question because most of the teachers who talk to you are government sector, they will not talk against the government sector. But I must tell you that when a patient brings to you tomorrow, Gopika, when you go, Amal, when you go to a health center, they come to your home, they fully think that you are doing the best for the child. Therefore, if you are telling them immunization schedule, government sector, fine, you should say that. But there are certain deficiencies. There are certain fundamental flaws of giving the 9-month-old Pentava 2+1 schedule for PCV, which is inferior to 3+1, and the hepatitis B schedule given in the government sector is completely flawed. That's what I would say. Now, what does the IAP say? The IAP, you said the IAP advises booster at 15 months. You are a postgraduate student. Has it changed for you? Has the slide changed for you?
I think
IAP immunization schedule has come. Okay.
yes, sir.
Look at the IAP immunization schedule. There is nothing at 6 months, and there is nothing beyond 6 months. They are not also advising booster doses. They are not also advising the shoulder 6 months. Remember, IAP takes a pessimistic attitude. The attitude of the IAP is we shouldn't say anything against the government. But the problem is, what is the IAP for? To give scientific matter knowledge to the children. But Kashi, who is the president of the IAP, who is the ACBPT committee member, he keeps on telling private immunization, it should be given. Now look at what the Nelson's textbook, he says, if a DT, has it changed for you?
Yes, sir. Yes, sir.
Yeah.
Okay.
Yeah, okay, read it out.
If the DTP, hepatitis B, and IPV combination vaccine is used, a 4-dose schedule is permissible, which includes the standalone hepatitis B vaccine at birth and the combination vaccine for the next 3 doses.
He says
CDC schedule is for
read it.
CDC schedule is for primary vaccination is 0, 2, 4, and 6 months. So last dose is given at 6 months.
Okay. Therefore, the CDC schedule has 4 doses in spite of the fact that 3 doses are required, because they also feel that for them to come at 6 weeks and 6 months may be difficult. Therefore, they give the 1 dose extra, 4 doses. But in our hospital, remember, we are giving 5 doses. Therefore, but remember, in Western countries, when they are giving 4 doses, the last dose is not given at first and last dose is not 16 weeks. This is IAP immunization schedule is also flagged here. The last dose is not given at 6 months. Minimum interval between the second dose and the last 2 doses, between last 2 doses should be 8 weeks. And between the first and last dose has been 16 weeks. None of this is followed by the immunization schedule given here. Now this is now in our hospital, our consultants, you ask Dr. Anju or you ask Dr. Karthik, are we doing the right thing? They will say, no worry, doctor. We don't give the 6-month dose, but we are giving the dose at 1.5 years. Okay? Mohsin, are you there?
Yes, sir.
Yeah.
Yes, sir.
They will tell you that, look, we are giving it 1.5 years, therefore no problem. We are giving it 1.5 years, and that will act as a booster. Yes, you are giving it at 1.5 years, but is there any problem? I just said that. Gopi, are you happy with that? Actually, that's the only thing possible probably, but I was giving it 6 months, tell you the dose later on. The 1.5 years is the 5th dose of hepatitis B which you are giving. Remember, you are giving at 0, you are giving at 6 weeks, you are giving at 10 weeks, then you are giving at 15 months. Therefore, that is the 6, 10, 14, 0 plus 15 will become 5 doses. Nowhere it is allowed to give 5 doses. You may say, what's wrong? We can give an extra dose. Even Nelson talks of the 4th dose, not the 5th dose. When you are giving, it's fine. But when something goes wrong, you can be problematic. Because if you develop an anaphylactic shock at 1.5 years, remember that the anaphylactic shock can happen even if the first doses are given normally. First 2-3 doses, no anaphylactic shock. The same vaccine can produce an anaphylaxis at 1.5 years. The problem of giving multivalent vaccine is that you don't know for which it was antigen it produces the anaphylaxis. Therefore, when you give in that situation, if you are given a vaccine which is not required, it will be very, very difficult to justify. Remember, IAP does not talk of a vaccine at 1.5 years. CDC does not. And you may say, okay, the Americans also give only, don't give 0-6 weeks and 6 months. They give 2-4. But the last dose of them, remember, the last dose, 2-4-6 months, the last dose they are giving at 6 months. Therefore, they follow the criteria. They follow the criteria by giving 0, 2, and 4 months. This is given by the IAP. And therefore, what does the IAP says? Can you see this? Has the slide changed for you?
No,
Hello?
sir.
Has a green slide
No,
come
sir.
in your phone also?
No. Okay. No.
Okay, carry on.
Hepatitis B to be given in 24 hours after birth. When this is missed, it can be administered at first contact with health facility. All stable preterm and low birth weight babies should be administered a birth dose and 3 more doses with pentavalent or hexavalent combination vaccines. Extra dose of hepatitis B vaccine is permitted as part of combination vaccine when use of this combination vaccine is necessary.
Now they are not telling which is the
IP.
fourth. That's enough. That's enough. Extra dose of hepatitis B vaccine is permitted as part of combination vaccine when use of this combination vaccine is necessary. Okay, but they are not telling how many extra doses. But Nelson says fourth dose can be given. Remember, this is the thing which they are telling, which our consultants will tell you. Even the IAP says extra doses can be given. That's the fourth dose, not the fifth dose. Now let's go back and go into the history and look at what WHO says. Okay. Can you read through this? Has it changed for you? WHO vaccination schedule, 2017 July.
No, sir.
Not even in your phone. Okay. When it changes, you start reading. I'll start reading. A 3-dose schedule, monovalent birth dose, second and third dose given in the first and third dose of DPT vaccine. They are telling. Monovalent birth dose, second and third doses. The first and third dose. That means they are talking at 6 and 14 weeks. They don't want you to give at 10 weeks. Or a 4-dose schedule, monovalent birth dose following 3 doses given with other routine infant vaccine. At least 4 weeks between the doses. They are not talking about the other things. No evidence to support the need for booster doses. Catch-up vaccination should be considered. Okay, that's enough. Now this is what see, there's given in Plotkin vaccine. WHO somehow supports our universal immunization program. I think the moment you have that yellow slide, you can start reading. I'll start reading. WHO.
So WHO recommends.
Yeah, read the whole thing.
Recommends
Very, very
multiple
important. Okay.
WHO recommends multiple options for adding hepatitis B vaccine to existing infant immunization schedule without requiring additional visits for immunization. Schedule should optimize the percentage of children completing the hepatitis B vaccine series, which can be achieved with early administration of vaccine. The WHO recommend minimal interval between doses 1 and 2 is 4 weeks, and the minimum interval between doses 2 and 3 is 4 weeks. Schedule with this minimal interval, example 6, 10, and 14, have zero conversion rates similar to schedules with longer intervals, albeit with lower final anti-HBs concentration.
The final anti-BIS concentration is lower. Now, can you read the whole thing again? Yeah. Has it changed?
No, sir.
It will change. I want you to read this yourself.
Same, sir. The WHO minimal recommended intervals for infant hepatitis B vaccination are shorter than those recommended in the United States. Although data are limited regarding long-term protection for schedules with shorter intervals, alternative schedules are often not feasible. In addition, concern about long-term protections are of less practical significance in countries of higher endemicity, where most HBV infections are acquired in childhood.
Now, let me summarize the instance for you what we have seen so long. That is, hepatitis B protection is very important, not only in newborn, but even in adults. Okay. And that is very important. Therefore, the principal doses, according to the basic principles of immunology, we are not giving booster doses. Why are we so concerned? Because it is not necessary. And one of the basis of immunization, not to give a vaccine unless it is absolutely necessary. All studies so far done on hepatitis B immunization has been with a schedule of 0, 1, and 6 months. No work has been done with the long-term immunity studies for doses which are 6, 10, and 14 weeks. But but even when you give 2, 4, and 6 months, the antibody titers are very low by the time they are 20 years. But no problem, because the memory cells are there, though there are no ready-made antibodies. Once the hepatitis B attacks and there's an incubation period of 50 to 150 days, the vaccine given at at 6 months, the booster given at 6 months is able to protect you. The doses which we give immunization in the universal immunization program in India does not give the last dose at 6 months, does not give a booster. Therefore, there is a problem whether the immunity will last long lasting. WHO does support it. Remember this. Therefore, but what does it say? Alternate schedules are often not feasible. Okay, not feasible in government sector, maybe in a country abroad. But will you be able to tell it to a parent that I did not give you because it is not feasible? He would have come at 6 months for your dose. Therefore, in your private practice, you might be fully justified in what our consultants are doing: 0, 6 weeks, 10 weeks, 14 weeks, and giving a booster at 1.5 years. Remember that you are giving a dose extra to the extra dose what already given applied. That is, you are giving 5 doses instead of even the 4 doses maximum advised by Nelson's textbook of pediatrics. Therefore, there can be a medical legal infant, but there is no other way. No other way. Otherwise, now already in the Indian Academy of Pediatrics, if you read the Purple Book, they have written in many kinds, it is time to revisit our schedule. Can we give 2, 4, and 6 months in private practice? They are making a hint at it here and there, because they cannot say anything against the government. That is understandable, especially in immunization schedule. They should never go against it. But when a patient comes to you and gives you hepatitis B vaccine, remember that if you are giving the 0, 10, 6, and 10 weeks, 0, 6, 10, and 14 weeks, the best choice for you would be to give the booster at 1.5 years. You cannot miss the booster as is advised by IAP or by the National Immunization Program. I hope it's very clear. It's already past 5 o'clock, I think. Am I? What's the time there?
5-3, sir. 5-3, sir.
503. What we will do is, I thought I would finish this. I have used only 56 of the 91 slides. Whatever's remaining, I would like better participation from you. Come when I log in at exactly by even 5 minutes earlier. I find you take a longer time. Go to a library early. Log in through the library net as well as in your computer mobile, because otherwise when the slide changes, it becomes a problem. Please show more enthusiasm, okay, to come and join. All right then. Okay. Hello, by the way. Hello. Are you there?
Sir.
Yeah. The topics that are,
Yes,
there
sir.
are topics which are important. The most important is catch-up immunization. This is a very important topic. You will have to know all the knowledge to know how do you immunize a child 8 years who's not unimmunized. Or how do you immunize a child who has undergone a bone marrow transplantation at the age of 5 years? What will you do to a splenectomy patient, etc.? Therefore, these special situation, immunocompressed, preterm, these things will have to be discussed. That may take one session, 1 week or 1.5 week, and then we go into individual vaccine. Now, individual vaccine, I'll give you
Okay.
I will give you the names in which you have to prepare and come, like BCG for Mosin or
Okay.
something. Some real vaccines
Yes, sir.
which has to be discussed, like polio, like pneumococcal vaccine, rabies vaccine. I might present it myself. Okay. Therefore, I will give in
Okay.
this soon.
Okay.
I'll give you the list. Start preparing. Don't tell me the date may come after 1 month. I want you to at least see 3 things. One, based on the purple book, WHO position paper. These 2 things are important. Look at Nelson also. If possible, Piyush Gupta.
Okay.
Remember, the purple book is important.
Okay.
The most important is the WHO's guideline, position paper. Okay. Google it, go to the and read the
Okay.
original from the latest from the website. You can download it and then read from the PDF. Okay, then. Okay.
Okay. Okay.
Bye.
Thanks.
Thank you. Ah.